My name is Ronnie Fass. I'm a professor of medicine at University of Arizona. And my discussion today was on the topic nonerosive reflux disease, should we reduce our expectations? The main points that I raised in my presentation was the fact that one, we have to recognize that nonerosive reflux disease is a much more difficult disorder to treat as compared to erosive esophagitis. And there are several reasons for that. The one that everybody knows about is the fact that nonerosive reflux disease is a heterogeneous disorder, meaning there are patients with different disorders that compose this patient population, and each type of these patients have different response to PPI treatment. And this is commonly known. But there are other reasons for failure in this patient population. One of them is the fact that when you look at patient response to PPI treatment, there is a close correlation between the extent of esophageal acid exposure and response to PPI once a day. The greater the acid exposure, the better the response. Unfortunately, most of these patients have only mild abnormal pH, which comes with a very limited and modest response to PPI therapy. Other issues are related to the study design of these patients. All the studies in nonerosive reflux disease are limited to 4 weeks. And as a result, we don't know what happened after 4 weeks in this patient population, and it is unknown. What we do know that during these 4 weeks we see an increase in response to PPI once a day, and it could be that we don't get the maximal evaluation of the response rate in this patient because we don't follow them more than 4 weeks. And the last thing, we use a lot of clinical endpoints that we borrowed from erosive esophagitis in neurotherapeutic trials, including, for example, complete resolution of symptoms, which we all know that this type of endpoints are associated with a relatively low symptom response rate. So my conclusion from this presentation that in the case of nonerosive reflux disease, knowing all these limitations,